In a typical tractional retinal detachment case, there is either absent or incomplete posterior vitreous detachment. The aim of surgery is to remove all traction and vitreous, so that we can avoid iatrogenic tear and prevent post-operative hemorrhage. First, we cut the anterior-posterior traction of incomplete posterior vitreous detachment, in order to avoid peripheral tear during manipulation at the posterior pole. After that, we start to concentrate on posterior pole. We clear any area of hemorrhage, to facilitate the exploration of traction, and finding the plane to work. We need to identify the posterior hyaloid plane, and gently lift it up while observing the vitreoretinal traction. Stop at any point of strong attachment. We induce posterior vitreous detachment gently, in the absence of strong attachment, and keep the cutter at the retrohyaloid plane. Engage the edge of the vitreous using the opening of the cutter. Attempt detaching the posterior hyaloid at the optic disc. In the presence of strong focal traction, disconnect the attachment around it using the cutter. Once completely clear of traction, detaching the vitreous is completed up to periphery. You may apply gentle suction while detaching the remaining vitreous, concurrently keeping an eye on the retina for any residual strong attachment. Complete removal of posterior vitreous detachment is important to prevent postoperative vitreous hemorrhage, as well as postoperative retinal tear. Vitreous schisis is very common in diabetic eyes. Always use either triamcinolone or dye, which help to identify any residual vitreous or traction. I always prefer to peel the internal limiting membrane, in advanced diabetic eye disease cases with fovea sparing. At the end of the surgery, apply pan-retinal photocoagulation. Then proceed with fluid-air exchange. For this case, endotamponade is not really necessary. We prefer short-acting gas, to avoid hypotony and rebleeding postoperative.